In this matter, Executive Chairman of the Queen Elizabeth Hospital, Mrs. Julia Sutherland, to address the matter as well.
Thank you, Honourable Minister, and thank you for that question. I just wanted to add, just to make a small intervention. Member Parliament Cattle, you are correct that it would be a seismic change in terms of thinking about the use of healthcare grants. And as our minister and others start looking at insurance and other models and new approaches to financing healthcare, it does lend itself well at that stage to looking at how we can build those kinds of measures into how we look at financing and placing some responsibility back on. But in this Honourable House of Parliament, I think it's also important that your question points to the fact that good health care, prevention of disease, is not just the responsibility of the Ministry of Health. It is the social determinants of health, early childhood education, food, as the minister just spoke to, access to housing and recreation, environmental pollutants, and other factors that impact on how people access disease and how people are impacted by factors that cause ill health. So my intervention is for this Honourable Parliament in thinking about how we can prevent the onset of chronic diseases, to take a whole of government approach and particularly invest in every minister and every ministry essentially becoming a minister of health and a ministry of health, and looking at how we can advance the agenda for the prevention of disease so that the hospital does not come, which is the highest cost center of your healthcare system, the recipient of the burden of carrying treatment of diseases that can be prevented by social interventions.
Dr. Brown also wants to make an intervention.
Just a small intervention, Honourable Member. We speak about incentives offered to the public with respect to NCDs, but I just want the public to be aware that there are other measures, almost negative incentives, if you want to call it that, where some jurisdictions have added to the taxation on sugary drinks. So on the one hand, rewarding a potential patient or a patient with financing, for instance, there are also the negative incentives, for want of a better term, where you put more taxes on some soft drinks, for instance, and sweetened drinks, where we insist by policy on labeling of items that are anti-NCD, if you want to call it that. There are incentives like that we can use to get the general public by policy to adhere to, just like we did for cigarette smoking. We put warning labels on alcohol ingestion, that kind of thing. So I think this is also going forward. I'm seeing it, and Dr. Phillips and us will work together with respect to forming policy to make some of these things law, where you have to basically increase the taxation. I think our taxation on sweetened drinks is extremely low, if I'm correct, Dr. Phillips, through the chair. So these are things we have to look at too, apart from rewarding patients. Make it so that you basically have no choice. Make rules within the schools where you insist on a certain amount, beverages are not allowed over a certain quantity of sugar. Make sure that the vendors outside of these schools adhere to these rules. Of course, the school meal service plays a part. And as the Chief Executive Officer said, you have to involve parents and the other, as I said earlier, to the other partners in the ministry with respect to starting somewhere with the efforts. But we need to start from base, ground zero, more to speak. That's it.
Just to say thank you very much for those thorough responses. Dr. Brown, I feel so strange to call you Minister Brown, Dr. Brown. I hear you on the disincentives, but what we learn, in particular from behavioral economics and from understanding how people respond, is that you get perhaps a lot more mileage from rewarding good behavior and sending signals in that way than from punishing bad behavior. So perhaps there will be time for us, we talk about these matters all the time, you and I, so perhaps there will be time for us to explore that some more. But I want to thank you, ministers, and the colleagues in the ministry for your responses.
Minister, I agree. But that being said, it has been done. I think it's St. Lucia, correct me if I'm wrong, where they actually made it into policy and law that taxation be raised basically on sugary drinks. So while it works better to provide honey rather than something bad, these are things that we really have to consider. That's it. And Minister Brown is strange to me too.
Thank you. Thank you, Honourable Member for St. Thomas.
Thank you very much, Mr. Chairman. Good afternoon to all my colleagues and the distinguished members of the Ministry of Health, and I want to thank you for the privilege. I have 3 observations, and I would wish to first speak to, in short measure, to the community healthcare nursing that we have seen starting to revive again. Oh, this is impacted. I beg your pardon, sir. When we are limited in technology, you must forgive me, sir. I wanted to commend the government and the Ministry of Health of the initiative with the community health care program that has been, I'd say, reintroduced, because I knew it would have been in effect many years ago and it served an excellent purpose. And therefore, I think that it will continue to pay dividends, because we have thousands of persons across Barbados who, due to a number of matters, are unable to visit the clinics, the polyclinics. And I recognize that there are times when people are there to get in early, sometimes as early as 6 o'clock in the morning. And when the polyclinic opens, the younger folks usually get ahead of them. And then some of them wait until 2 and 3 and 4 o'clock. And it really makes it difficult, especially if they're persons who have challenges to do with diabetes and all that. And I think that the visits in the communities help. As a younger person, I knew of that kind of project going. And I knew when nurses and others came to the schools and tested children for vision, other impairments, the visual impairments, the hearing, and so on. And it really worked very well. But I know that many of our seniors, because of their comorbidities, they cannot get out to the polyclinics. And so in the same way, and I know that those visits will make a difference, especially those who have been released from the hospital and all that, and then they have to have dressings to get back to the hospital. They have to have transportation. They have to be moving around in the wet weather. Some of them have mobility challenges. And therefore, I think it is a wonderful initiative that will ease or eliminate the plight of families and caregivers when it comes to that. So I'm really very much in favor of it. And I must tell you that I have seen and witnessed some things happening at our some of our health institutions, with the long waits and the negative vibes and the poor treatment, the insensitive comments that people are meted out to people, the intolerance, the frustration. It really is not a good experience. I, having had mine not long ago with an old man at one of the polyclinics, and I thought it was most unprofessional and disrespectful. And I'm not saying that this is happening everywhere, but that night when I went there, it really was beyond. And it was only God's mercy that I'm a Christian girl that I really did not kick up any dust, because I feel that people should be treated with the best form of professionalism, and that is not across the system. A lot of people in the system are cared for well by nurses and doctors, as well as the other members of staff on the compound. But I believe that some element of training needs to take place for even the ancillary staff in some of the institutions. I am not here to mention them, because I'm not going to say anything disparaging about any area, except to say that across the board, there should be training so that people can know they are dealing with human beings who are the pillars of this society. By their sweat and their tears, they have built this society. And when the aged and the disabled go to some of those institutions, they're very poorly treated. And I want to thank those who came up with the vision, along with the Honourable Prime Minister, who forever was saying it, and my niggling ones, because of my old age, that I was able to talk about what I knew that a lot of young members in this honorable chamber are not familiar with, because perhaps they were in a position where they could pay the doctors and so on in the private settings, but there are too many thousands of people out there who rely on these services. So this is a wonderful step forward, and I want to highly commend those persons who are offering that quality service to our persons in the communities. My first query, though, sir, comes with the Albert Graham Center. And usually most of those persons who are disabled, who have to use those resources, are poor people, those who are most vulnerable and impoverished, I should say. And therefore, I am happy. I was made to understand that last year there were some plans to have the facility upgraded. It had really run into disrepair for a while. And I wish to say how happy I am to see efforts being made that poor people's children can get the necessary support. I had looked and I saw in the estimates, and I'm not good at mathematics or anything, but I tried, just over $1.5 million last year, and I think this year is going up to $1.795 million. And I believe that we should be really investing more. I had the distinct honor, I should say, while in the classroom, of teaching 3 children at different stages, 3 or 4 year period, where this one mother had 3 disabled children. And I saw the love and the care that she put in her poor way to be able to make sure that they met the needs, and the schools, of course, and others in the communities helping her. And I think it is about time that we pay more attention to our disabled in this society, making sure that their special needs are looked after. There's usually limited funding. Monetary support is not there in the same way. And of course, the parents cannot pay their way. So I am happy to see that there are some improvements. And I would wish to encourage the other entities, because I always talk about the synergies when it comes to the welfare department, and so that those children get the benefits that they deserve, rather than having to go on any list and then be eliminated because it is a review. These children need, and these young people and other clients who are disabled and have gone through the system, need to get the necessary support to be able to help to feed and to clothe and to look after them in the way that they should be. And I want to find out if the Ministry of Health is having closer synergies with the Ministry of Education, because all of the children are not impacted upon in any educable way. And I am a firm believer, as the slogan they had said, disability is not inability. And therefore, if the Albert Graham Center continues to work with the ministry, or starts to work in a more comprehensive way with the Ministry of Education, I believe that the mainstreaming within our system will help them to show up what their strengths are, and to help them through the system so that they can become even more independent as they move from strength to strength. So I would like to know exactly what is happening in relation to those synergies with education, and of course other agencies that will help to strengthen the bonds and to help to educate those parents of the disabled or those who are a part of that institution, because I think it is about time that the society not only looks after those who are at the levels of education at university and in the other schools, and so they need to spend more money and put more resources, I should say, human and otherwise, into the Albert Graham Center. And that is my first comment and query, sir.
Thank you, Honourable Member. And I do agree with you that training is essential and a very critical component of any future success of any entity. And therefore, the Ministry of Health will be continuing their training opportunities, and therefore, and will also be encouraging those persons to maintain the necessary training standards that they're used to and have become accustomed to. Of course, COVID would have interrupted some of our planned activities over in this current financial year. But as we move to manage COVID and we get back to the basics of managing healthcare, we are going to be emphasizing and re-emphasizing training opportunities at all levels, not only polyclinics, but all throughout the ministry. In respect of sub-program 381, the Albert Graham Center, you are quite right, Honourable Member. You would have realized that there's a an increase in the vote of almost proposed increase of approximately 260,000. And that is essentially to take care of those persons who are challenged, as you correctly identify. We cannot leave those persons behind. Their challenges must at all times be addressed. And therefore, after a review of the center, the ministry indicated in its estimate that it would require additional funding to upgrade the plant, and therefore we are going to upgrade the plant to the tune of approximately 260,000. Specifically, if you look at 751 on the plant and property, there's provision for 244,000, and also an increase in machinery and equipment for the center. There's an issue with the roof in the walkway that we have to fix in order to make sure that we make them as comfortable as possible, and we are going to do that. And also security system. There's an urgent need for security in that at the center, and we have proposed the increase there, and we will be executing that program once the estimates are approved. In respect of the Albert Graham Center, I would like to ask Dr. Ingrid Cumberbatch to give us additional details in respect of your question. Dr. Cumberbatch.
Thank you, Minister. Dr. Ingrid Cumberbatch, Senior Medical Officer. With respect, thank you for your question, Honourable Member. With respect to the Albert Cecil Graham Center, as you so correctly said, there would have been some renovations that would have undergone between 2019 and 2020. They I think were completed in 2021. But of course, as Minister would have said, there is still the roof and the walkway that needs to be repaired. The education unit, as you know, that is a component of the Albert Cecil Graham Center. But as you also very correctly said, the links between that unit and the Ministry of Education definitely need to be strengthened, and it has been something that has been identified, but I regret to say there's been not much work done in that at this point in time. So there's something that we're looking to do and endeavor to do in this coming financial year, strengthening the partnership with the Ministry of Education so that those persons and those teachers can have the support that they need, that Ministry of Health can't give them, but the Ministry of Education will be able to give them so that they can improve their plans for the students of the Albert Cecil Graham. Thank you.
Thank you, Dr. Cumberbatch. I believe that would have answered your question, I hope, Honourable Member.
Thank you, Honourable Minister. Mr. Chairman, I also, for my second question, I want to focus on the alternative care of the elderly. And I feel that there should be a more holistic approach when the clients, the patients, if you want to call them that, should be transferred from the Queen Elizabeth Hospital where they're occupying critical beds that will really be of great service to persons who require them in order for them to be sent to the alternative care, be a part of the alternative care program. I know that the numbers keep climbing. I am extremely disappointed because there are persons in the system, meaning generally in Barbados, and some families who believe that they can just take their seniors and leave them at the hospital door, and it must be determined that they must keep them there because they can no longer look after them. And I know that it is really not an easy task if you have parents and guardians and others who are down with the dementias and the Alzheimer's and all that, and the challenges that you can have with them at home. It's not always easy to care for them, especially if that only caregiver is the only breadwinner in the family, so they're carried to the hospital, and I don't think that we should be taking our elders at all and leaving them there. And so I want to learn exactly what is happening, because the additional funds I see here again, it's about 150,000 more than last year. And I know that that is only, for me, a drop of water in the sea, when having had the experience in the last 3 to 4 years of numerous calls and visits, seeing persons who really require the alternative care, and the pensions that they're getting Sometimes they get the non-contributory amount, which is just under $500 every 2 weeks. And then it really cannot pay for the services. And you know, the Honourable Member for Christchurch West spoke very profoundly about the kind of funds that would be required to care for those seniors who would be transferred from the hospital or from the various communities into the private homes. I know that over the years that we had meetings with the persons responsible for some of the private daycare facilities as well as the private homes. And when we look at what they're receiving through government, is woefully inadequate. And so I would want to find out how we can go forward. And it cannot be just the Ministry of Health. I think there needs to be, again, closer communication and synergies with the Ministry of People Empowerment and Elder Affairs, because that is where every day there are no less than 50 calls or 50 requests for persons to be able to be transferred to those facilities or to be accommodated there. But unfortunately, there's no authority in the People Empowerment Ministry. And so I would like to be able to get word from the Ministry of Health as to how we can pursue going forward, acknowledging the kinds of challenges and the suffering that is taking place when seniors are left alone. And that we also acknowledge that our society is an aging one. And if our people are living longer, we are having more senior citizens that are becoming centenarians and so on. We really need to look at educational programs across the board. The Alzheimer's Association is doing quite a bit, but we need to have more use of the public fora so families get to pick up when their relatives and so on are coming down with the disease and all that in order to make a difference. We need to even focus as well on more facilities for respite care, because that is another area that we're having quite some concerns. And so I want to commend the government for the efforts and to finally say through you, sir, there's a woeful lack of gerontologists in the country. And unless we have the National Disabilities, the National Development Scholarships, recommending persons and giving them the opportunity to do the studying and then making sure that they're assigned to come back here and practice as a part of the contract, we are spinning top in mud. We cannot have so many thousands of persons, 80, 85, 90, 100, 106, only one last week was buried. We can't have that and not plan strategically to cater to the needs of our seniors when we have limited persons trained. I know that the Queen Elizabeth Hospital has some nurses that are in the program, but we need more gerontologists to look after them, bond them as we should with persons that have scholarships, that get the scholarships, they go overseas, not only those scholarships, but the ones that are given at the end of the secondary study, and then they never come back. And so the brain drain is there. And I would like to know what plans the hospital has, again with the Ministry of Education, to make sure that we have at least turn out 2 gerontologists every year so that persons can get the necessary care. Not everybody is going to come to the hospital, but we would want private trained doctors and others at that level to be able to take care of our seniors who really, at this time, more than any other time before in our history, need to have the kind of care that is here. And so, sir, I would just like to have some reaction on that I can get some assurance that when I get back to the 450 people who I see on here every week asking about health care for seniors, that at least they can get an element of assurance that they know that there will be plans going forward, not only for their families, but for us as well. I am going over the hills, and they know that, and many of us are, and we need to know what is in place for us to get some care so that we can know our lives are safer and that we are in better opportunities to extend our lives in our right mind where possible, but with the necessary care to support whatever else happens thereafter. Thank you very much, sir.
Thank you, Honourable Member. Before I hand over to the Permanent Secretary to address the matter, I would like to agree with you that there are several issues in respect of the alternative care for the elderly that we have to look at. I think we need a policy position on this whole issue of alternative care for the elderly. And we have to start thinking outside the box and look at maybe futuristic concepts. We also have, in my judgment, to look at the whole issue of our senior living and how senior living could be incorporated in a broad policy to encourage persons who are often left at the Queen Elizabeth Hospital and elsewhere. Now, on that matter, I should like to inform you that at the Queen Elizabeth Hospital, we do have a challenge with elderly being left at the institution. On any occasion, we can have upwards of 25 to 36 beds out of what you call urgent patient care, because we have to care for the elderly. Now, there's a system that we have in place that we transfer those who are left at the Queen Elizabeth Hospital into the geriatric hospital and other hospitals. But the capacity at the bed capacity at the geriatric hospital stands at 278. And within the elderly, the alternative care for the elderly, we only have approximately 35 beds. Now, there are expanded opportunities, and I think there are expanded opportunities for even private sector people to get, private sector investment to get involved in, because clearly the government can't carry the entire load. But at the same time, we have a moral and social responsibility to look after those who've been left at our institutions. So we're going to work on a policy position. We're going to work with the ministry that you had the honor to lead, Honourable Member, when you were Minister. We will be working with several other stakeholders to devise such a policy, because we simply can't allow the Queen Elizabeth Hospital to become overrun with persons who have been left there. We have to keep it for emergencies and persons who are awaiting procedures to be done. But at the same time, we have a duty, a national duty, I might add, to look after our elderly, and therefore a policy position will be forthcoming. What I'd like to do is to ask the Permanent Secretary, the Most Honourable Jeanette Phillips, to speak on this matter as well. PS.
Thank you, Minister. For the record, I am Janet Phillips, Permanent Secretary in the Ministry of Health and Wellness. And Honourable Member Ford, you would have raised some issues that have been a concern for us in the Ministry of Health and Wellness. Certainly since I've been there from January 2020, we have been plagued with the issue, as the Minister would have alluded to, of having many persons left. We call it elderly fakir, and we also have a carrier of person called young fakir. These people are being left in the QEH, they're not being collected by their relatives, and then the burden then falls on the persons at the QEH hospital to manage them, as well as manage critical care persons. And it is an issue that we've been trying to grapple with whilst trying to deal with the issue of COVID. We have put a temporary measure in place where we have now turned what was formerly the St. Lucie District Hospital. It had been had transitioned from being a district hospital to a quarantine facility. We've put it now as a quarantine facility for those persons, those elderly persons who have been left at QEH, to transition there until we can find spaces in the geriatric system. That in itself is still a challenge for QEH, and on a daily basis, we get the reports of persons who are left and they are clogging up the spaces, not only in the oxygen and emergency, but and they're also taking up valuable bed space that is needed for critical care patients. We are actively trying to renovate what was formerly the Elaine Scanterbury Center. We're working on the roof. We're hoping to get it finished before the end of this financial year, so that will free up an additional 28 bed spaces so that we can help the QEH relieve some of the congestion of the elderly persons in the hospital. But you know, when there's a vacuum, then there's room for persons to then bring more persons. And the issue is a wide issue, and I agree with you, Member of Parliament Ford, that we need to have a really expansive educational program. You need to take care of your family, and if you can't take care of your family, then you work in collaboration with the Ministry of Health and Wellness to help them. But QEH should not be a dumping ground for old people who have labored and toiled in the fields and have sent us to school and made us men and women. People come and they dump their family members there and don't look back.
and then they leave the whole burden on the state. It has to be a collaborative approach. And so therefore, we welcome the opportunity to work with the Ministry of People Empowerment and Elder Affairs. Honourable Minister for Ministry of People Empowerment, you will be soon hearing from Minister so that we can have discussions on how we deal with the elderly. The Ministry of Health and Wellness is responsible for dealing with the elderly who are sick, but those who can still be in the community and get help even from their neighbors, we need to put some mechanism in place to help them. I remember growing up and having elderly grandparents, what we would call grandparents in the neighborhood, but the whole neighborhood looked out for them. But then everybody in the village raised families. That is so absent these days that is so unfortunate, but we have to get back to that sort of approach where we look out for the elderly who can stay in their homes and just get some sort of assistance when they need people to check on them to make sure they're doing fine. And while we're at it, let me hasten to point out that we are very shortly going to be embarking on construction of a new geriatric facility at the Botanical Gardens, lovely spot. The aim is to build out 400 bed space capacity. We don't currently have that at geriatric, so there'll be room, Member of Parliament, for additional persons to be able to be housed in this facility when it's finished built out. It will not just for persons who are elderly for care, it will also be for people who want to have a retirement space there so that they can be in a conducive environment. So the plans are very well in train, and we're hoping that sometime next year we can see massive improvements in that area. You mentioned the whole area of respite care for persons with Alzheimer's, and I am happy to indicate that we are in the preliminary stages of having designs done for Alzheimer's respite care facility, which will be housed where the current Gordon Cummins District Hospital is located, because the few patients who are left there will soon be relocated to the St. Philip District Hospital when we have finished renovating some wards to house them. So we do have plans in place for that. They're at the preliminary stage. PM has indicated that she wants it to be a PPP arrangement where we build out and hand over to be managed, not by the ministry itself, but by private care persons. So we're working on that as well. You mentioned the increase in relation to the alternative care for the elderly. That increase relates to an increase in fees paid over to those persons for housing elderly care persons for us, because for the last 15 years we've been asking for an increase. We've not had any persons are crying out that the cost of taking care of the elderly has risen high, and we have responded to that. We didn't get as much as we wanted, but there's a start, and I'm hoping that next financial year we will be able to get a bit more so they can get fees more commensurate with what it takes to actually take care of a patient. Lastly, Member of Parliament, you indicated that there is need for more persons trained in gerontology. I'm sure that when I'm finished, the Executive Chair can speak on her behalf, but I know from my end in the Ministry of Health and Wellness, we're trying to put a training program in place where we have more nurses trained in gerontology. I know it's not a sexy area, but I know that it's still an area that needs to be taken care of, so we will be dealing with that very shortly. And have I covered, Madam, all of the areas that you've raised? I don't want to not answer any questions. Lastly, yes, I agree with you. We need to have gerontology as one of those specialties for the National Development Scholarship, and therefore when the circular comes around to the Ministry of Health, that will be one of the inputs that we'll be making. Thank you very much.
Honourable Member, I will also ask the Executive Chair of the Community Hospital to speak to this matter as well.
Yes, thank you very much. And I think you're correct, MP Ford, that there is a need for the training of more gerontologists and geriatricians, physicians who specialize in elderly care. And at present, the University of the West Indies Doctor of Medicine program does not have that as part of its repertoire of care. So it is something certain that we are going to have to fund persons to go overseas and train. I'd like to add, while I have the microphone, that in addition to respite care and daycare centers, we think the Ministry of People Empowerment, who has responsibility for driving the policy in this area, really should also look at issues such as carers' allowances, It is proven over time that if families can be provided with resources to help with the care of persons and keep them in their homes, that this will be much more cost effective to the government. This is done in England, Canada, and other parts of the global south. So there are a range of options for improving the care of the elderly. Certainly we will do our part to put in resources or request resources for the training of physicians and other staff in the area of geriatric care.
Thank you, Executive Chair. Thank you, Honourable Member.
Final one, please?
You're welcome.
I'll make it short. I know this is the one that is going to take away most people's hearts, because I find that our citizens seem to look at mental illness and scoff at persons who may, for whatever reason, have to have some kind of mental break or have to suffer from some form of depression. And I think it is something that needs to be removed from our psyches, because as far as I'm aware, anybody can have a mental break, have a depressive moment, and so on. And that is why, as a younger person, I chose to be a part of the bereavement services, because persons become depressed when they lose a loved one, when they lose their employment, when they lose even a pet sometimes, then they have to lose properties. And at this time, where we are going through COVID and so many people were unable to work and all that, they would have gone through some depressive moments. I've had about 4 or 5 within the last 2 weeks of persons whose properties are up because they could not go to work during the COVID time, and they're getting problems from the financial institutions. Some people, because they crop over, they're always fed kings and queens, and there's so many other challenges that are impacting on our people. And I would like to know what form of sensitization programs, beyond the few Zoom activities I've seen from the psychiatric hospital, that I always call the psychiatric hospital, as well as the district hospital, the outside children really in the healthcare. And I really shouldn't do that, but some of the things I see and know really make me feel that Barbadians must take a serious look at what we are doing when it comes to mental illness or aspects of persons who become depressed for whatever reason, knowing that each of us is a human being who could be here today in our right minds, and tomorrow whatever activity causes us to, or experience causes us to become more reserved and to become ill, that we would want to be recognized. And we know of many outstanding people across the world. I mean, there's one world leader now that I feel that he really has to be more than mental ill. With what we are seeing happening in another country that they have taken over, and all kinds of loss of life and so. And I would like to know what programs are being put in place for families and for the general public in relation to persons receiving desensitization programs to do with mental illness, psychiatric matters, because we are seeing it every day, and with the upsurge in our young people and others who are caught in drug situations, or they've been made homeless and the depression kicks in. I would like to know, because I think that those kinds of programs will help families to better understand their roles, similar to what we are doing with the Alzheimer's Association and other forms of sensitization, to make the difference in the lives of others. And I have to close by saying thank you very much for all that you've been sharing with us, because at the end of the day, no one knows when it will get on their doorsteps, or in their workplace, or in the churches, or the institutions in which they have to function. And so I think it is everybody's business in Barbados to make a special effort to learn about mental illness, depression, and so on, and to be able to help those among them to mitigate those individuals having to go to the farthest extreme, telling them what signs to look for and how to treat to the matters to be able to make a difference. And therefore, I would wish to hear from those distinguished persons in the Ministry of Health, particularly those in the psychiatric hospital area, what are some of the things that are on the board to help us, because we've got the technology now, and for me, that will be wider spread for other people to be able to pick up the skills, and each of those institutions to form some kind of association of friends or something that will help to strengthen what the professionals in the institution will be doing to make a difference in the lives of all those persons who are impacted upon. And that is my general comment. I wish to thank you, sir, ladies and gentlemen, for their time and the experience.
Thank you, Honourable Member. I should let you know that the Ministry is currently working on a revised policy for mental health. And as I indicated in my opening remarks, we have to look at modern mental health strategies. We're aware of this is becoming, particularly during the last 2 years, an area of concern to Barbados. And we are definitely going to be working on and bringing that revised policy to the Cabinet for the necessary approvals as we seek to modernize mental health. What I would like to do is to ask Dr. Brian McLachlan, who is a senior consultant psychiatrist at the Psychiatric Hospital, to elaborate on this and other mental health related challenges. Dr. McLachlan.
Thank you, Minister. I'm Brian McLachlan. I'm the senior consultant psychiatrist at the Psychiatric Hospital. And thank you, Member of Parliament Ford, for your question. I think, as you have quite rightly pointed out, the past 2 years have been difficult times for all of us. We know certainly from international statistics and from anecdotal statistics here locally that there has been an increase in mental health conditions, anxiety and depression amongst them, for persons who have had challenges with regards to the pandemic. And this is challenges that are related to the physical aspects of the pandemic, as well as those related to what you refer to in terms of persons who would have had some socioeconomic fallout as a result of that. I will say certainly that the staff at the psychiatric hospital, certainly both doctors, nurses, and other paraprofessionals, have been involved in both providing care as well as providing, as you said, some of that sensitization that needed to occur. And because we had certainly some of our own internal issues with COVID, then we were very busy both working, but recognizing the need to also provide services to outpatients and persons in the wider community, as well as to provide sort of education and support for persons. What we're doing moving forward, certainly, and you may again remember, Member of Parliament, when you certainly were in ministerial chair, that certainly we would have again been in partnership with your ministry with regards to persons who had again been displaced by the hurricane and the tropical storm, and recognizing that persons so displaced from a home point of view did need services, and we did again partner in terms of being able to provide certainly some services as was required. We have also, since last year, we've been working with the Ministry of Education, recognizing that the whole issue of young people being out of school was creating quite a lot of difficulty for our young people, and wanting both to provide support, education, and services to young persons in our schools, but also those who are looking after them at school, that is our teachers and some of the ancillary workers as well. And we were able to provide some educational discussions, yes, on Zoom, but to both teachers, social workers, and counselors that were in the Ministry of Education, and we were helped out in that matter. What we are hoping certainly to do moving forward, and obviously we're mindful that COVID is not quite finished yet, but we are looking past that certainly, and recognizing that people have had difficult times and still need support. We have always had, and we've continued to have, our community mental health services in the polyclinics. We recognize that during COVID, because of space needing for those sorts of services, that there was some displacement, but we recognize that persons needed help, and really the numbers who are attending those clinics had actually increased. And we are happy to serve, but we do recognize sometimes that the wait times are a little bit longer than we would want for them to actually be. We also certainly continue to have our services at the assessment unit at the psychiatric hospital, and we recognized again during the period that there was an uptake of persons who were presenting. We realized that persons, again, perhaps because of some of the displacement in the community and persons who would normally go elsewhere to access mental health services, did find themselves coming to the psychiatric hospital. You did hint at stigma where that was concerned, and that's always an issue for us. And that's something that we have ongoingly been trying to address as well. Our community services in general, and certainly our community mental health nurses, our community consultant psychiatrists, and we do have an in-hospital psychiatrist who are tasked specifically with doing more mental health education. And obviously we're using Zoom because it is what is happening. But as we move out of that environment, then obviously we're hoping that we're going to be able to do perhaps more face-to-face seminars and interactions. That's something we've always wanted to do prior to the onset of COVID. It's what we actually had planned to do in terms of providing a certain number of those sort of interactions in the community, wherever they need to happen, churches, schools, wherever. But we had certainly worked out that we wanted to increase the number of those that we actually do. And then COVID stepped in. And so I'm expecting certainly, because the need is there, that as time goes on, we are going to be getting back to doing a lot more of those sorts of interventions. October is usually Mental Health Month, and at that time, one normally sees quite a bit of a blitz in terms of information coming out through GIS and other media outlets. And what we talked about doing is really not waiting until October perhaps, but trying to do a lot more during the year so that we do have a constant message of mental health and mental well-being that needs to certainly go out into the community. We realized with regards to persons who were coming into hospital with mental illnesses that because we had cut down on visiting, we weren't necessarily able to interact with families as much as we wanted to. And again, that's perhaps going to change as we perhaps may start to allow some more visiting at some point in time. But it's important certainly that once persons come into hospital that we do spend time trying to engage families, making sure that they're aware of what is happening, sensitizing them to what's happening as far as the particular illness that their loved one is suffering from, providing education and providing support, especially as those persons then transition out of hospital and back into the community. The last thing I will say at the moment is with regards to what we have hoped to happen, but which has not quite happened for a number of reasons, which is really to assist in the development of more support groups in our community, persons who will come together, perhaps service users, interested family members, really to provide support for persons who suffered with mental illness and mental health difficulties. We really would want for those groups to be formed, to be community-based, and we want that we'll be able to provide certainly education to those groups as opposed to us running them, because we do want, I think, the community to be able to help themselves, to be able to be advocates for what they need in terms of mental health services, and to be able to provide support for those persons in the community who need mental health care. Thank you.
Thank you, Dr. McCartney.
Thank you, Honourable Member for the City of Bridgetown.
Thank you, Honourable Chair. I want to start where my colleague and brother from St. Michael West started by commending the last Minister of Health, the Most Honourable Lieutenant Colonel Jeffrey Bosted. And I also want to say that when I look back with pride in the work that the Ministry of Health and Wellness have performed. But I also look forward with optimism because I'm very aware of the bodacious nature and approach of the current minister. I've watched what he's done with a number of agencies and ministries under his hand and how he's been able to transform, improve, and bring a sense of hope to the people of Barbados. I'm also very aware of his colleague that sits to the left from St. Philip North and what she brings to the table as well. So I look forward with optimism. With that said, I want to state that I've always looked at the Ministry of Health as really like a ministry of sickness, a ministry of treating sickness. I remember in another place organizing youth parliament and looking at cabinet and asking myself, why should we name this the Ministry of Health and not name it the Ministry of Sickness? When we added the word wellness to it, I got a little excited because I said, we begin to get it now. We need to look at wellness and prevention. And we've spoken some bit to that this morning and this afternoon. But I want to go to the estimates directly in sub-program 40, the Health Promotions Unit. And to start by saying that while statistics can be a little dangerous, I see that we've almost doubled the amount that we're looking at in relation to health promotion. But that has doubled from 0.001 to 0.002. So we've gone and we're now looking at spending about $680,000 in order to look at health promotion. My question, Mr. Chair, as I consider what Dr. Phillips admitted is a bit small, is what are we looking at as a country and as a ministry in prevention when we're talking about health going forward? What type of behavioral change programs are we looking at? Who are the players in this? Is it going to be doctors? Is it going to be change agents, psychologists? Who? When I think of a Ministry of Health, just like the Executive Chair, Ms. Bino Sutherland spoke about, I believe that it should be a whole of government approach. What is the Ministry of Education doing? What is the Ministry of Sports doing? Ministry of Youth, Ministry of Information? What are we doing truly to bring a comprehensive approach to the prevention of the health challenges that we are seeing, costing us almost $500 million a year in relation to fixing these problems, many of which are preventable? So I want to know, in summary, what are we doing in a comprehensive way for behavioral change to prevent us having to spend this money?
Thank you, Honourable Member. I would also remind you that within the Health Promotion Unit, the unit is responsible for promoting healthy lifestyles, a comprehensive nutrition policy, and also encouraging healthy eating and obviously lifestyles. This is part, as I indicated earlier, part of our NCD program, a non-communicable disease program that we plan to execute based on the mandate given to us by the Prime Minister of Barbados. What I would like to do is to ask Dr. Arthur Phillips to expand on this very critical area. The sums voted will continue to help us to promote our programs within the ministry. Obviously, we would like to have received more funding, but we understand, the nature of revenue management. And therefore, we're going to have to look to other mediums in order to expand and communicate and message to the country in order to achieve the goals. Now, fortunately, first, we have social media. We have other social media platforms that we could utilize to get our messaging out. But the critical thing for us will be for us to get into the schools, working with the Ministry of Education to continue to promote the program that we envisage. The program will be an extended program, and even though the sums voted that we've requested and the sums that the Ministry of Finance would have agreed to in the proposed estimates would seem to be very small, we believe that we could use a process of getting into secondary schools, getting into the community to promote these programs, working with the ministry responsible for community empowerment to structure programs where we can get a lot of our field officers and other healthcare professionals into the community to help us spread the word. We believe that if we can do that, we would, I think, get greater bang for the buck, as they say. But at the same time, we would commence the process of encouraging persons to lead healthy lifestyles. So I will ask at this point Dr. Arthur Phillips to speak to this matter. Dr. Phillips.
Thank you, Minister. Thank you, Chair. The health promotion unit has a challenging task in supporting all of the programs of the ministry in health communication, partner engagement, creation of healthy policy, promotion of prevention. Of course, key within that is the NCD support and support for not only the NCD Commission, but the work of the Wellness Task Force. And there is scope for, we have had in the past, a cabinet subcommittee on NCDs. We believe that even with the funds provided, as Minister would have said, I believe the figure that you're seeing in front of you is 680,000, but I've been informed by the financial controller that the figure is actually 503,000, as 177,000 has been adjusted away from that. So the health promotion unit works in partnership with other ministries, and therefore we're able to extend the impact of the resources that we do have available. And one of the key means is by empowering persons through health education and through connecting them to opportunities. So the work there is large in scope, but we believe that given the technical resources that we have, and given the way in which the unit can collaborate with other partners, partners in the media, partners in the NGO sector, we can continue to have a positive impact. The issues in terms of the school nutrition policy, the issues in terms of the cancer prevention plan, the issues in terms of the NCD plan, all of these are tied into the work of the health promotion unit, which also, of course, supports the work of environmental health, pharmacy, family health as well. So this work is going to continue to be key to advancing our efforts. We do believe that the unit will need to continue to have appropriate resources available to it. Certainly as we submit the updated NCD strategic plan, we are going to ask for the resources to be made available to deal with staffing and building out and delivering on the NCD agenda. But as I said, health promotion has impact and involvement beyond health communication, and engaging with the NGO sector, engaging with the private sector, and helping individuals to understand how they can better live healthy lives through messaging and through incentivizing them and providing opportunities for them. That is going to continue to be part of the mandate of the health promotion unit. Thank you.
Thank you, Dr. Phillips.
Thank you very much, Dr. Phillips, for that. For me, I've heard, sometimes size doesn't matter, so what my greater concern is, and I wanted to ask a follow-up question, but I will move from that to basically begging that the ministry put some serious consideration, or continue to put some serious consideration on the idea of prevention. When I pick up reports and I see 62% of beds at QEH are occupied by NCDs, preventable lifestyle diseases, I do believe that we can make significant inroads if we put a little bit more investment, time, energy, creativity, et cetera, in relation to prevention. prevention, nothing to be scoffed at whatsoever. And I know that the ministry will continue its work in terms of prevention. I heard about the community health programs and all the other various educational programs, and all I am doing is taking this opportunity to make a plea that we continue to put some emphasis and increase the already existing emphasis on prevention. I move on to my second question, Mr. Chair, which is in relation to a situation that has been haunting me for some time, and I recognize that we did bring on a number of workers, temporary workers, albeit in relation to addressing the idea of COVID. And it's within these very honorable chambers that we, the public of Barbados, was educated in what temporary means. But I do understand that a number of persons were brought in to address COVID, and that as COVID now takes a shift into an endemic from a pandemic, we understand that there is some shift in the workers. I like to be forward thinking, and you know, we have to do something with those workers. Just like in 2018, this compassionate government set up the household mitigation unit to address the number of persons going home, so that it won't be a case that we just sending home people, but that we put a platform to transition people into something, transition them into another form of livelihood. I want to know the ministry's plan. I want to be assured that we will not just tell people, wham, bam, thank you, ma'am, that we have some form of plan, some form of methodology for addressing these breadwinners, these single mothers, these people who have been gaining some form of income by putting into this country in its darkest time, looking after those COVID patients in the quarantine and in isolation units. I want to know if we have a plan to address the transitioning of workers, many of them from the city of Bridgetown, I will tell you, but also many of them that fall under my portfolio in the Ministry of People Empowerment and Elder Affairs as well. So I need to find out from the ministry what is the plan for those many, many workers who've helped us out over the last 2 years.
Thank you, Honourable Member. If you go to the program vote for COVID, subprogram 6201, you will note that as we anticipate the management of COVID, we will also have to look at, in a very wholesome way, how we manage issues. Now, I will say to you that no decisions were taken in respect of any of the facilities that we are currently engaged in, save for the ones that were contracted as quarantine hotels. Those obviously, based on the trending that we are seeing in respect of the positivity rate, we've taken the decision within the ministry, because obviously the resources that will be given to us in the next financial year would not allow us to continue with those. As we move towards the policy of home quarantine as well, that will obviously have to reflect the positions taken within the ministry. In respect of the workers at all the other facilities, like I said, we have not, Harrison's Point remains in operation. Yes, we accept that based on the trending, and if that continues, there will be an opportunity for us to look and see what we can do at the Harrison's Point. We have to explore, as I indicated in my opening remarks, what do we do with the Harrison's Point site? Do we look to create opportunities for joint ventures, and do we look for opportunities where we can maybe clear some of the backlog at the community hospital, if it would allow, once we have a situation where the number of COVID patients there will be at an absolute minimum. So there are ideas that we're discussing, and we will look at those very carefully and have the appropriate responses. In respect of the other facilities that we have, we still have to manage. For example, we have workers at the Grantley Adams International, based at the Grantley Adams International Airport. They help us not only with flow of traffic, but they really help us to maintain port health at our borders. And port health is a very important and critical nature. So I can't tell you now, because obviously, based on how the estimates are constructed, we are continuing to manage. We are going to continue to manage the COVID situation. The Ministry of Finance, they have given us the appropriate resources. At the same time, we have to recognize that COVID has had a significant call on the government's budget over the last 2 years. And as we move to a situation where we're going to have to manage COVID and we're going to have to work and live with it, we have to do so in a very sensible way. And Honourable Member, it is something that we will pay attention to. It is not a situation where we are going to simply be, engaging in any wholesale exercises. There are some facilities, obviously, that we will have to review in depth. But at the other time, on the other hand, we have to look at overall the facilities that we have in place and how best we can reposition those facilities to help us expand and upgrade and manage healthcare in Barbados. I will pause here and ask the Permanent Secretary to come in, and then I'll come back.
Thank you, Minister. Thank you, Minister. As Minister would have indicated in the estimates of expenditure, if you look at the errata that we received today, there's been a significant decrease in the quantums of funds allocated to the Ministry of Health and Wellness for the next financial year. If we check what was allocated in the current financial year, we are not even getting half of what was allocated, especially as it relates to 102, which is other person emoluments. That therefore has significant implications in terms of cost of salaries and how we can retain persons going forward. Minister have correctly indicated that we have not made any definitive decisions in relation to all those persons who have been brought on for COVID, except in relation to persons who would have been working in the quarantine, catering for persons in quarantine. We no longer have anyone in quarantine. The decision going forward is that quarantine will not be paid for by the government of Barbados, and therefore any person who comes into country who has to quarantine will be quarantining at their own expense. We have expended significant sums in also paying for not only isolation facilities but quarantine facilities over the past 2 years. And as the DFE always tells me, the government no longer has this fiscal space in which to do so. And we as good civil servants have to follow suit. So the sums allocated under 102 for other personal emoluments, that's where repair temporary officers has been cut significantly. It does not even amount to a year's salary for those persons. So we are working in-house to make sure that we take decisions that we know the decisions that we make will impact, but we're trying to minimize the impact. We have not determined what that will look like as yet. Even though the positivity rate is coming down, we do not know what will happen in a few months' time. And we have been told by finance, if such a thing happens, when we have an increase in positivity rates and high numbers on the ground, then the financing will have to come, because our national response has to be one that is very impactful, as it has been over the past 2 years. So yes, MP, there are implications for labor, but I'm not at this point in a position to speak definitively on that. I can't afford to be put in naughty corner. We have to do it in consultation, not only with the two ministers, but also in consultation with the Ministry of Finance, who is the final arbiter. So some decisions will be made, those have not been made as yet. Persons who would have been let go from the quarantine facility, there are only 8 persons, and I'm not trying to minimize that, but they will be given what is statutory due to them. They'll be given a month's pay and loan notice, as well as any vacation pay owing to them, as is the custom and practice in the public service. Thank you.
Minister Brown wants to come in.
Just a small comment, Member of Parliament, and this serves as a source of comfort to me. One should bear in mind that some of the staff that were used during the COVID were transferred from the Queen Elizabeth Hospital and other areas, the polyclinics as well. So the public is aware of a shortages in staffing with respect to nursing care. And it serves as a source of comfort knowing that some of these people that were put toward the COVID effort are returning to their substantial posts. So that's, in essence, not a loss of job. The other thing I wanted to say, while visiting the Harrison Point facility, I noted that the Most Honourable Corey Ford had started, and his staff had more or less started a program, rather unofficial or otherwise, where he sought to train existing staff at every level so that they're more equipped to take on further workload, and the possibility of job seeking is there. For instance, he had taken people that had come on the lower level, orderlies and so on, and had trained them such that chances are, at least theoretically, they'll be able to fit into other areas within the public service or the Ministry of Health. So while the possibility exists that we may be cutting, bear in mind that some of these people that you're wondering will just go back to their substantive posts. With respect to the paucity of nursing staff, the public is well aware that we had issues with the no degree program at the Barbados Community College. And through measures that were taken, the pass rate now is like 75%, which is a great increase. So these would be nurses. We had brought in many, remember, from Ghana and Cuba. They're not meant to be long stay nurses, as far as I'm aware. So that being said, we have 4 years of nurses that will be equipped and well trained to take up positions where there is a need for them in the polyclinics and the hospital setting, geriatrics as well. Thank you.
I will also ask the Executive Chairman of the Queen Elizabeth Hospital to make a few remarks.
Minister, Chair, through you, our new Minister, Ian Gooding-Edgehill, has encouraged us as a hospital to develop, in addition to a 5-year CapEx plan, a plan for the staffing of the hospital. It is recognized that right now the Queen Elizabeth Hospital is not a 24-hour facility. And as we look to expand and provide services more efficiently and effectively over a 24-hour period, there is going to be a need for some additional staffing. But we want to do so in a rational way. We want to make sure we achieve all the efficiencies that we can achieve. And given our minister's background, he is intending, as I understand it, to look very scrupulously at what our plans are going forwards. So I do believe, Member of Parliament Ford, that the opportunity may exist, and as you heard Minister Brown speak, to transition. Corey Ford, it's on my brain. Minister Lane, that as we work with our substantive Minister of Health at our staffing plan for the hospital, there may be opportunities to transition persons, so once we do so in a rational way and within budgetary parameters.
Thank you. And just let me add, the Harsons Point facility, for example, that costs us about $1.1 million in average a month, or approximately $13 million per year to run. What Dr. Corey Ford has done down there, short of remarkable, in terms of training and developing staff. As Minister Dr. Brown had indicated, close to 3 Fridays ago when we visited, I must say that I was very impressed with persons who started there as an orderly, and they're now enrolled in PAHO and other courses at the University of the West Indies Mona campus online. And for example, when I was there, I got an understanding of their client relations department. And there's no way that we would want to allow such talent that would have been trained and the levels of training to which they would have gone to to allow that talent to go to waste, and we're not going to do that. We are going to work with, as the executive chair of the hospital indicated, once we have the areas where we have shortages and we can address those shortages, we will look at those very carefully and see how best we can realign human resources. But safe to say that the Ministry of Finance indicated to us that if we are in a position and we require additional funding, well, as long as we make a solid case to the Ministry of Finance, they will consider it. So at this point in time, I would say that we will continue to manage all our facilities as we respond to the management of COVID. And if there are any proposed changes that we have to look at or we have to examine of a financial or human resource nature, we will certainly investigate those and do what we have to do. Our goal is to continue to manage COVID. At the same time, we have to improve our facilities. And like I indicated, there are future plans. For example, I talk about the potential in my opening remarks for Best Dos Santos lab. I talked about future possibilities for the Harson's Point. And we also have to look at and see what we're doing in respect of the backlog of surgical and non-surgical procedures that we need to attend to. And therefore, once we put the plan together, I'm confident that we will be in a position to make the appropriate recommendations to ensure that we can utilize such facilities to help us to achieve our mandate in healthcare. Thank you.
Thank you very much, Minister and team. I feel a lot more assured. I feel better listening to the responses of the entire team. I pray and I hope that the many, many persons reaching out to me with a degree of nervousness that they too were listening, or that my team can clip the response and have it sent on to them. My final thing, Minister and Ministry, is the incinerator. The incinerator. I am here today to beg, to plead, to beseech for something to be done with the incinerator at the QEH hospital. 2 evenings ago, I sat here and watched my phone go berserk. The people complaining about the pungent smell. I know these things do happen, but it was particularly bad on Monday evening. I did some asking around, and I was pleasantly surprised to hear, well, it's in the estimates this year, only to have the proverbial rug tugged from beneath me. They told me it was in the estimates over the last 3 years. And then further to that, doing some more asking around, the rug not pulled now, pushed up on the ground, because they told me it was there for the last 13 years. I want Minister to beg and plead and ask the question what can be done, and if the ministry has even examined any modern advancement in incineration. I know we had a company knocking around here called Cahill talking about zero emission incinerators. I want to know what is the position with the incinerator in the city of Bridgetown. The only thing I could have done on Monday is to leave this place and go down there and sniff in solidarity, as the incinerator caused a number of issues, respiratory and otherwise. And I'm begging the ministry and pleading with the ministry in asking what more can this honourable member do?
Thank you, honourable member. First of all, it is always difficult when a member of parliament has to find himself in that situation. And we clearly, I understand, because I, like you, represent people, and they will on occasion put the case to the member of parliament, especially if there are issues that are considered to be a nuisance or a bother to them. Honourable member, let me indicate to you that the incinerator, as presently constructed, was there for a while, and since 2013, I believe recommendations would have been made for it to be, replaced. I'm happy to report to you that as part of the European Investment Bank loan, that we are going to have a new incinerator at the Queen Elizabeth Hospital. I cannot give you the timelines as I speak to you, but I can assure you that as part of that loan package, provision has been made for the replacement of the incinerator. For too long, we've been spending a lot of money on recurrent expenditure on the incinerator. It's akin to, as they say in where I used to work in my other life, it's like putting lipstick on a pig. And therefore, we have to part with that. So I will be in a better position once we are, once we have all the details in respect of the AB loan, to give you an update. And I promised you that I will give you an update when we're at that point where we can get it going. But it is a source of concern. And the Queen Elizabeth Hospital itself cannot continue to be paying upwards of $300,000 and $400,000 annually to just repair an incinerator that's past its useful life. This is one of the commercial decisions that ought to have been taken long before we were in government, since before 2018. But truth be told, it is what it is. But our mandate now is to fix it, and that we shall do. So I can assure you and the residents of the city of Bridgetown that a new incinerator will be coming. But like I indicated, I cannot give you the specific dates when we will start the construction, but I'll be happy to do so at a later date. Thank you.
Minister, on behalf of a grateful constituency and a grateful nation, I thank you.
Thank you, Honourable Member for St. Peter.
Thank you very much, Mr. Chair. I have a couple of questions for the Minister, or probably his officers. I'll begin, though, by recognizing the work done by ministry and hospital officials over the years. I think the work in addressing the impact of the pandemic is probably, history is probably going to show it as legendary. And I think we really owe a debt of gratitude to all those men and women involved in the fight to combat COVID-19 and its impacts. I also recognize the work done to improve in the accident and emergency department. And of course, a lot of commendation goes to the former minister. And I know the current minister, with his experience and his intent, will build effectively on what has happened before. I begin in terms of question where the Honourable Member for the city started. And that is sub-program 0040 of program 040, so the health promotions unit. I ask, from the perspective of being the minister responsible for the third sector, the specific question or the angle that I want to come from is to find out from the ministry what is the intent, is there any strategy or plan in terms of linking with third sector organizations. There is a mention in the estimates document of engaging and linking with stakeholders. I'm speaking specifically to third sector organizations. I'm aware that you do have relationships, particularly with those third sector organizations that are health oriented. I'm asking, beyond those that we are familiar with, we heard some of them today, Alzheimer's Association, diabetes, cancer. There are other third sector organizations, and I'm wondering what strategy the ministry has in terms of engaging with them in the fight against the NCDs and any other health challenges that may exist in the country. That is my first question.
Thank you, Honourable Member. Yes, there is a plan to link third sector organizations as well as churches and other interested parties. Health promotion, as I indicated earlier, must be seen as something that cannot only rest with the polyclinics and the Queen Elizabeth Hospital. It must be extended beyond those public institutions. We have to get into the community as well, and that's why I said earlier that we will also work with the ministry responsible for community empowerment to help deliver the messaging that we need in terms of healthy lifestyle, nutrition, and so on. But I do take your point in respect of the third sector interest groups, and we are going to be working with those. I will hand over to Dr. Arthur Phillips, who will be in a better position to elaborate on the involvement of the third sector. Dr. Phillips.
Thank you. Thank you, Minister. Thank you, Chair. The Health Promotion Unit continues to lead on engaging with stakeholders, inclusive of the faith-based organizations, NGOs, the private sector, media, academia, cultural actors, etc. It's one of the strategies of health promotion to engage in partnerships and collaboration. The point being made that engagement should not be limited to traditional health partners, I think, is an important one. While it may seem easier to engage with NGOs and other actors who have traditionally been active in terms of contributing to health, there are significant benefits to be accrued in engaging with other partners. So that Health Promotion Unit engages with faith-based organizations. We actually have a document that speaks to how faith-based organizations can be engaged in conducting activities that improve health. We do engage with NGOs, and you'll be familiar with many of the NGOs that are active in terms of improving health. So you'll be familiar with the Heart and Stroke and Diabetes Foundation, Diabetes Association, Cancer Society, Cancer Support Services, and many others. In terms of the private sector, we do have partnerships. In COVID, we've continued to have private sector engagement. So across our areas of activity, whether NCD or as we've been focusing on COVID, there's a role for the private sector. This work of engagement is not always an easy work to do, but one of the things that we have committed to doing, and we have in our plans for this year, both from a health promotion point of view and from an NCD point of view, is to contribute to the formation of an NCD alliance. We believe that the NGOs in Barbados, while some of them have coalesced around issues of childhood obesity prevention, there's a wider NCD agenda, and that the NGOs working together can be more productive. They can complement each other's strengths and achieve more and collaborate with the ministry more effectively if they are organized through some more formal structuring across their units. Additionally, the work of the NCD Commission is intended to have that sort of multi-sectoral coordinating effect to it, where it includes the labor unions, it includes the private sector, it includes key government departments, and it helps with the understanding of and the influencing of actions across the various stakeholders that can improve health. At the higher levels, there is potential. We have had in the past cabinet level mechanisms for all of government NCD policy, and we believe that there is potential for this to contribute again. Another actor in this space has been the Wellness Task Force, and again, this mechanism has engaged not only the traditional NGOs, but the private sector, whether it be insurance companies, whether it be just large companies that can benefit from having an increased awareness of the benefits of contributing to the health of their staff and contributing more widely to the community. All of these are activities that are conducted and will continue to be conducted by the Health Promotion Unit. So the sectors to be engaged, I take the point, it is an important one. We're not limiting ourselves to the traditional health NGOs. We are engaging with the wider actors to ensure that health is attained and maintained. Thank you.
Thank you, Dr. Phillips.
Thank you very much, Minister and Dr. Phillips. I heard mention of the NCD Alliance. The question I'd asked really had to do with the strategy. What I heard were what the plans are in terms of that we will engage with them. But I'm hoping, given that I'm making an assumption that the strategy may not be fully yet fleshed out, I am really pushing to say that there must be a strategy devised that would see that collaborative approach that is maybe at this point in the minds of those of you in the ministry. And I'm looking forward to seeing what the NCD Alliance will show. I maybe should mention at this point, since you mentioned the National Task Force on Wellness, I'll mention it here. I should have mentioned it to the minister before, but it's only now come to my mind, and that is that the ministry that I have the responsibility of leading has a relationship with the Ministry of Health in relation to wellness, and pursuant to Cabinet's approval about maybe 2 years ago of the National Workplace Wellness Policy, we established a committee that would focus on workplaces, working hand in hand with the Ministry of Health. We were very clear to set out that we are not into duplicating efforts or treading on toes. And so the ministry is represented on that committee, as well as the chair of the National Task Force on Wellness also represented on that committee. So that facility already exists, and I've instructed my ministry to know that we're almost in a post-COVID situation to put some pedal to the metal where that is concerned in terms of its reviving, so that we are able to do our part in helping the Ministry of Health and Wellness execute on its mandate. The second question that I have is more parochial. It speaks to, well, I'm here asking this because of the people in St. Peter. And in Program 360, Primary Healthcare Services, sub-program 0408, this refers to relates to the Morris Bayer Polyclinic. I'm just asking questions maybe because of my background. I see utilities increase pretty significantly, and I'm wondering if it is pointing to something maybe like increased hours, extended hours, because I see utilities mentioned in the current financial year that is coming to a close, 135.7 thousand, going to almost 206,000. And then I see supplies going from 128,000 to 216. The question I have is this a signal of extended time frames, expanded opening hours? Does it mean additional services being provided? What does it speak to?
Thank you, Honourable Member. At 4.8, the increases in respect of the account 207 utilities represents what is an accurate figure for utilities. It doesn't speak to additional opening hours. It merely reflects what we're actually spending in utilities. And what we did, we made a representation to the Ministry of Finance to bring it to its realization. Because if we have a situation where we are spending over 200,000, but we are only receiving maybe 130, 135,000, we will, at the end of the financial year, we will have to make a request for a supplementary, or as we have to do annually, or we will have to allow that bill to exceed the required number of days, credit limit days, and then deal with it in the next fiscal, and then we start off with a deficit. So this is essentially just a budgetary element to reflect currency in respect of utilities at the Mar.22-P2 Polyclinic. In respect of materials and supplies, it's the same principle applies. I've been advised that it has been under budgeted, and therefore the appropriate representation was made to the Ministry of Finance to bring it up to what we believe is an acceptable level. Clearly, you don't get everything you asked for, and we understand that. But that amount is to go to satisfy supplies and materials so we can maintain the required service delivery. Might also add that with rising costs, we are experiencing, this is across the entire ministry. If you look and see the cost of freight, when you even have to buy, for example, drugs, you're seeing an astronomical. I actually asked for, in the case of drug service, for an explanation, and I got that explanation. But this is reflective of what we have to do. We would have loved to have received more on the assets under construction, because we know that we have to replace the floor in the administrative wing. Obviously, we can't get that yet, but as progress is made with our government's revenue, and if we can make the appropriate recommendation in case to the Ministry of Finance, provided they have the resources, we will then seek to see if we can get an increase in the vote to undertake the necessary repairs. So as it is, the Mar.22-P2 Polyclinic, Honourable Member, will continue to operate as is. Thank you.
Okay, thanks. Well, at least I'm happy that the budget is now an accurate number as opposed to what existed before. My final question is, this relates to the emergency ambulance service. And I know that there are appliances, well, no, you don't call them ambulances. Appliances are the fire tenders. But at the Arch Hall Fire Station, and I'm just curious as to what improvements has the QEH seen as a result of placing the ambulances at Arch Hall? Because I know they were placed there to allow for speedier response from calls from persons in the north of the island, north and east, I guess. So I'm just asking, well, north and northeast. I'm asking just for maybe an update, a little bit of a report as to what improvements have been seen. Has it been enough to cut down response time? That's really what I'm asking for. Thanks.
Thank you, Honourable Member. Yes, I have been advised by my colleague at the Queen Elizabeth Hospital that there is one ambulance at the Arch Hall facility. While we are on that, I should let you know that we have 7 ambulances on the road. We have another one to be procured via the QH's capital expenditure plan. there's also one that will be donated by, I believe it's the Maria Holder Trust, and that will be matched, that one donation will be matched by another by the government of Barbados. And then we are going to proceed with the replacement of another ambulance that was involved in a vehicular crash and was written off. So the proceeds from the insurance company will go towards the purchasing of of an additional ambulance. Now, what I've also asked is that we look at a fleet replacement policy for the ambulance service, and we have to do that. And we, as you know, we already have 2 ambulances dedicated to the COVID-19 response. But specifically in respect to your question whether or not we've seen an increase in the response time, I will ask the representative from the Queen Elizabeth Hospital, Ms. Brown, to address that matter. Sorry. Bob, sorry, to address that.
Louise Bob, Director of Support Services, Queen Elizabeth Hospital. And thank you for the question, Honourable Minister Jordan. And yes, generally with the concept of decentralization within the ambulance service, it allows for a decrease in the call response times. The golden rule is to respond to emergency pre-hospital calls within the golden hour. That's the concept. And with the decentralization of our service to the Arch Hall fire station depot, it allowed us to have a faster response time to the calls coming from the north of the island. So between headquarters or Queen Elizabeth Hospital and headquarters and the response to the various parishes, the longest response time should be within 45 minutes. And with the Arch Hall assignment of our ambulances in that particular area, we've been able to keep within the 45 minutes, and under. We receive on a daily basis a matrix of data on how the ambulance service has been responding to calls from various parts of the island. So I can assure you that yes, the placement of a unit at Arch Hall has decreased the response times.
Thank you very much. I had a personal experience where I had to call an ambulance for a family member not too long ago, and the response was speedy. And I just wanted to find out, the reason for the question was really to find out if that was a common thing. I also should indicate to you, Minister, and your team, that the paramedics were exceedingly helpful. These are not things often that maybe should jump out at you, but sometimes we get so many bad experiences in our interactions with people. But they were kind, they were compassionate, they were considerate. I don't often have interactions with paramedics, but the 2 gentlemen that I had interaction with were supremely professional, but also very, very kind. I would just conclude with a comment to say, Minister, that in relation to the Marsbell Polyclinic, we in St. Peter will continue to do whatever we can to assist. We don't have vast resources, but we've provided a television set for the polyclinic. We've also provided some picnic benches on the outside, and whatever we can do, we will continue to do to support that healthcare institution in the constituency and parish of St. Peter. Thank you very much.
Thank you, Honourable Member, for your contribution to the Marsbell Polyclinic, and also for your kind remarks in respect of the paramedics. Thank you.
Thank you, Honourable Member for St. James South.
Thank you very much, Chair. I want to start by congratulating the Ministry of Health and Wellness for their commitment, despite challenging circumstances, limited resources, limited staff, in seeking to keep this nation well and healthy. I know it is not easy. I just have a couple of questions. There are two areas that I'm concerned about that perhaps we have a gap in the service delivery that has an impact on a section of the population that we might need to address maybe some improvements as to how we go about doing so. The one area was the situation of where a family is dealing with a person who has a mental problem. Very often the problem gets worse and worse, and the resulting stress, both for the person who is affected by the illness and the family that is seeking to cope with the behaviors, seeking to get assistance from the mental health facility. There's a process, but that process seems to be challenging in order to be able to get the necessary care. And from my understanding, there's a shortage of resources as well, which exacerbates the problem. I have to thank Dr. McLaughlin for his assistance, because he was able to step in and help me with two of my constituent families that were struggling, trying to cope. I want to know what facilities and what resources are going to be available to further assist dealing with this particular challenge of mental illness, and whether that has been provided for to help expand or change how we approach dealing with people with mental illnesses and the support that we give to those families. That's my first question.
Thank you, Honourable Member. Indeed, I've heard about such situations before. What I would like to do is ask Dr. McLaughlin to address your specific concerns.
Good afternoon, Honourable Member. I can't actually remember those circumstances that you were just referring to, but I hope I can be of assistance now.
You dealt with them very well. Thank you.
Thank you, Honourable Member. I think let's start at the beginning. I think if it is that we have a family that is having difficulties with a family member, usually the first thing that will happen is a call will be made perhaps to our assessment unit. The family members will give information with regards to what's the concern, and if that's really the situation, it often means that the family members are not able to get assistance for the family member where the affected individual is willing to receive that help. And so if the assessment unit is contacted, then usually the community mental health nurse for that area will often be asked to go to visit and assess the situation, and usually then in a discussion with either the community consultant psychiatrist for the area or myself as the senior consultant, then we make a determination as to what's the best next step. I will say certainly, and the reality is that what family members often want is for persons to be admitted to hospital, and to be admitted to hospital for a long period. Because, and I keep coming back unfortunately to COVID, but because of COVID, where we have to be concerned with persons being admitted, having to quarantine, and mindful therefore that for persons to quarantine, we are using single rooms. And because we then also need single rooms for persons who are disturbed, and often people being admitted to hospital are disturbed, then there are challenges in terms of resources with regards to placement in hospital. And that's just the reality. So what we will often try to do once we are aware that there is a difficulty is, if there is space, if immediate space, then perhaps the person can be admitted. Otherwise, we do try to manage the situation as an outpatient. And sometimes that's successful and sometimes that is not. perhaps because, again, we get different family members calling, or it's different days of the week, or sometimes the family members, you know, they will call and they don't think that the response is fast enough, then they will be, you know, calling persons to try to get additional help. Each situation is different, and therefore all I can say is I think if there are ongoing issues with trying to get appropriate and effective help for a family member, then if the reality is that it must come then to the clinical head of the hospital, then that's just the reality, or even the administrative head of the hospital, as in the hospital director. But often we would want that these situations are handled through the community services if it is, as I've said, the individual is not prepared to voluntarily come and seek help, either at the hospital, in its assessment unit, its outpatient department, or in the community at the community polyclinic, then it may be that certainly additional help is going to need to be borne to bear to get that individual the help that they need. Thank you.
Thank you for that response. And if we could make available to families via PSAs and so on, information on how to go about it, because by the time your entity gets to intervene, they are so stressed and so distressed that it is really challenging for them even to interact with you in a positive way, because they've really been stretched out by this process of trying to cope with someone who is not able to be mentally stable. So if I could make that suggestion. The other area would be the area of depression. It was raised by one of our other members. What I want to ask is, are there any plans, you may not have it in this budget, but if it is something that you're thinking about, I'd be glad to hear, because depression has been more widespread across the country, and I think over time our people have become more comfortable, should I say, or less negative about having depression and having certain stress conditions, recognizing that they need help. We need to have some type of hospice care where a person who is suffering from depression can go and get a step away from their situation and be able to get some kind of support, psychiatric support, psychological support, until they can recover their balance and learn to manage their depression better. My question is, do you have plans and resources, or is this something that could be pursued as a public-private sector partnership to look at providing some kind of hospice care for persons who suffer with extreme depression?
Yes, thank you very much. We'll ask Dr. McLaughlin again to respond. But I think there are some other clinical issues. I'm sure he would wish to respond to those as well. Dr. McLaughlin.
All right. Good afternoon. David Leacock, Hospital Director, Psychiatric Hospital. Thank you, Honourable Minister, for the question you posed relative to the matter of depression in the elderly and the need for persons to have sometimes what we call not hospice care but respite care. We recognize that there is a market there for persons in the private sector, for example, to come in and actually assist the ministry as far as this is concerned. We have explored possibilities of what we call day hospitals in the past, but there is not the resources at this point in time to explore that beyond that, as far as just the exploratory stage thus far. So we are hopeful that in time we can see public-private partnerships come into play to support the hospital as far as that aspect is concerned.
Thank you for that. And if perhaps we could, there may be other areas of healthcare that could benefit from public-private sector partnerships, and perhaps a publication in a public place of what some of those things could possibly be. It makes it easier for people to identify what are some of the things that they could support by making investment in those areas. My last question has to do with the whole digitization of records and making it easier for a person who has to interface with health institutions to not have to go back over their information. I want to know how far along you are with the digitization and what is being put in place, for example, to preserve the privacy of that data. Well, I know you would be looking at information sharing. What will be put in place in terms of data protection so that a person, yes, can get the necessary care and ease of care, because the health providers will have access to the information, but at the same time, what we put in place to protect their privacy so that, that information then does not become public for all and sundry to have access to.
Thank you, Honourable Member. I believe earlier in my remarks, I alluded to the fact that the Queen Elizabeth Hospital, working in conjunction with the Ministry of Health, and this is a project that will be led by the Minister of State in the Ministry, Dr. Brown. And the issue has to be that we have to move to a platform where we have electronic medical records. Now, not only exclusively available to the Queen Elizabeth Hospital. What we have to do is to have medical records with all the necessary security levels in place to protect what you just mentioned, data security and patient confidentiality. But we have it that we can extend it as well to the polyclinics. And I also think that in terms of our global reach, we should also consider expanding that facility to general practitioners, so that if there's a major medical challenge, you don't have to rely on hospital, or you don't have to rely on information being solicited from elsewhere, that you have in a central information system, that information being made available to all registered medical practitioners and all those users within the assigned security levels. We are going to work on that. There's currently a database program that we have in place, and I will allow Mr. Junior Burgess, who's the Director of Information Systems, to speak to this matter. But it is a work in progress for the ministry. It is urgent and very, very urgent, and we have already commenced discussions in the ministry. Like I indicated, Minister Dr. Brown will be leading that task, and the sole objective is to ensure that we have patient information in real time available to all public institutions, and with the requisite security access to persons in private practice as well. But I will ask Mr. Junior Burgess to speak to what obtains now and where we are likely to go as well in the future. But I would also like to say that in any system that we agree to, we're going to have to look at how best we can consolidate that information and store it in one place, and the whole issue of data analytics and how we control that. And in any event, any software that the government of Barbados should procure, the government of Barbados will have ownership of that software and ownership to make the necessary changes, because we will not engage in the purchase of any software program or database program without us being in control of that system. But I will ask Mr. Junior Burgess to speak to the matter. Mr. Burgess.
Good afternoon, Junior Burgess, Acting Director, Information Systems, Ministry of Health and Wellness. So Minister Gooden is correct in that we've started, the QAH and the Ministry of Health have started to look at a system that will take care of all the needs of both QAH and the Ministry of Health and Wellness. And what we've looked at so far does have a component that we can engage even private doctors, and we can share information easily. We are piggybacking off of what the Ministry of Innovation, Science and Smart Technology are currently doing with their modernization program. Whatever we do, it will be housed within their environment. So our data will be our data, be following the ambit of the Data Protection Act. We are looking at, in this situation, where the record of the patient belongs to the patient, and the patient determines who have access to that data. So they essentially give a person permission to access their data, and all of this falls under what the Ministry of Innovation, Science and Smart Technology is currently working on. We are far along with identifying what we want, where we would love to go, but as always, as we discussed for most of today, the challenge will be one of funding. Is the funding available to readily procure this system tomorrow and start the process? While I hear about how urgent it is, I want persons to appreciate that there's a process involved. We have to make sure that we do even change management to make sure that the staff in the environment understand what we're doing and they're brought on board. So there's not something that we can just flip a switch. Software is easy to buy, but if you buy software without engaging your stakeholders and going through that change management process, invariably sometimes you can waste your money because you don't have that buy-in. So we want to make sure as a ministry that we cover all angles, make sure that our stakeholders are involved in the process. And so far we've done that. We've had several meetings with our stakeholders. We've demonstrated. We've had a sandbox where they can play with the various packages, and then we make an informed decision as to which software package can give us what we want. But critical to that also is then going through conducting training for our staff, making sure that the infrastructure is in place. So all these are things that we're currently working on to make sure that when we do procure a system, that the system is fit for purpose. As my colleague said to me, there's no one software that fits all of our needs. And therefore, we know that we'll have to do some customization. There are the packages that we have in place, and to make sure that all these software can communicate and information is passed from point A to point B is critical. We started the process, great for us, and the aim is that in the quickest possible time that we will complete this process and ensure that there's a new system out there that adequately satisfies the Ministry of Health. One of the key things that we look at when we were choosing this software is the ability to mine the data within this software. With our current system, when we require information, we go back to our provider. But with the new software we're looking at, we want that we can mine the data on our own and then make informed decisions to guide health and where health goes. So I think we are on a good path right now. It's just a matter of ensuring that the funding is available and then working with our counterparts to implement this system and solution.
That was very reassuring. Thank you very much. And Minister, I just want to say to both of you, both ministers, that I really appreciated what was shared when you first opened about the effort to reduce the backlog of cases, because as an MP, that is a challenge for me, where people have not been able to get their procedures done, continue to suffer. So I was very, very pleased to hear that, and I look forward to the changes that will be made to help us deal with it, that people can anticipate timely and good health care here in Barbados so that we can keep a very productive nation. Thank you very much, both of you. And your team.
From us, thank you too.
Honourable Leader of the House.
Thank you, Mr. Chairman. Allow me, first of all, to express certainly sincere gratitude to the former minister for the sterling work that he has done in relation to the management of the Ministry of Health and Wellness, and certainly for helping us through the dark days of the pandemic into where we are. I know that he could not have done it without the strong team within the Ministry of Health and Wellness, and I believe that the country will continue for some time to owe a number of the persons, not just who are in the room, but a number of the healthcare professionals across the country, a debt of gratitude for the work that they've done to keep Barbadians alive. I want to just follow on from the last point that was made by the previous honourable member, who spoke, and I think other members spoke about it in relation to concerns about backlog of cases at the Queen Elizabeth Hospital. I heard the Honourable Minister and the team in relation to the steps that are intended to be taken to address the backlog, and I think that that is welcome because all of us echo the sentiment that this is a major concern across our constituencies. But I want to hear from the Minister and the team specifically about the rationalization of consultancy services within the hospital. And I ask that because there are a number of people who raise the issue that they attend the hospital, they're seen by a specific consultant, and then for one reason or the other, they're then told that it would be faster to be treated privately. If they can come up with the money, they can be seen by the same doctor outside of the hospital, or that arrangements, I believe, can be made for them to be seen at the hospital if they go through the doctor privately. I don't think that up to this point that we've really heard about how this expenditure is made in relation to consultancy services. I don't know if we have any data that suggests how many people the consultants are actually seeing on a regular basis, how effective the service delivery is, what is happening in terms of the number of patients who are actually turned away and who fall into that category where they are forced to seek the services outside or seek the services privately. But it is a growing concern for me because I feel as though we are paying for these services, but we are not necessarily getting from the public a sense that they are feeling as though the delivery of this service is working to their benefit. So I know we are turning the corner in terms of the pandemic. I know that this issue has been around for a long time, but I'm curious, Minister, from you and the team, how do you see the next few years in terms of being able to address the issue of consultancies and professional services within the Queen Elizabeth Hospital?
Thank you, Prime Minister. Let me say that you are correct. We are going to address the issue of backlog. Perhaps it's my lot that I like a challenge, and therefore I consider this, along with Dr. Brown, to be another challenge. And I give you and I give my colleagues and I give the country the assurance that we are going to work to address this issue. Like I indicated earlier, we can't address the issue in 1 year or 2 years, but certainly with certain specific objectives being set and measurable delivery being checked on a monthly basis, we are going to be in a position to understand progress. Part of the issue with the backlog as well has to do with the fact that the institution would have to benefit from additional capital expenditure. As I indicated back in 2019, the government of Barbados would have made available to the Queen Elizabeth Hospital some $18 million in capital expenditure, and that was well spent. We have to go a step further and make additional investments. But in making the investments in capital expenditure, we also have to make some practical changes at this time. As I indicated, we've had approximately 700 or so persons awaiting cataract surgery, and we are putting a plan in place to address that. There are other surgical procedures that persons are trying to access, and we are getting an acute understanding of those. As I indicated earlier, I had tasked the executive chairman of the Queen Elizabeth Hospital to produce that information. As it relates to additional resources, once we have a look at the staffing levels and see where there are deficit areas at the Queen Elizabeth Hospital, we're in a better position to make a judgment and obviously an approach to how we need to resolve the issue. In respect of the consultants at the hospital, it is a work in progress. We've had a meeting with the medical committee. I will not at this time make any pronouncements. We are having additional discussions. The head of the director of the medical services at the Queen Elizabeth Hospital was there when we had, along with Minister Brown, when we had that discussion. So it's a work in progress. Once we've reached the stage that I can make a further public pronouncement, Prime Minister, I'll be delighted to do so. But at this stage, I know it is an issue, but there are several other areas that we have to address, including equipment, including making sure we have operating theaters operating at the optimum capacity, making sure that we have the staff to operate those theaters, and also utilizing other facilities that can perform some of these surgical procedures. So I will wish to say that at the appropriate time, once we've concluded discussions, we will be in a better position to do so. I also indicated in my opening remarks that we have a situation, and I do agree with you, where there's some persons who, when I said in my opening remarks, who went to school, worked hard, paid taxes to help educate those of us, and now they're in a state of pain, and we have to correct that. And it will take some time to do so. But I'm even more mindful that we have persons out there who have been waiting for an inordinate long period of time to get surgical procedures done. And it is my clear vision and understanding that we have got to address this problem. But there are several other areas and moving parts that we have to address. And once we've addressed those areas, I'll be in a better position to update you and the country in respect of the steps that we need to take. Now, the Queen Elizabeth Hospital, it is an issue of culture, and it's also an issue of processes. And we're going to have to change some processes without doubt. I'm not going to sit before you and say to you that we are not going to change. We have to change some of those processes. Like I indicated earlier, the status quo at the Queen Elizabeth Hospital will no longer be accepted. But we have to do it in a very judicious manner. We have to do it by involving the stakeholders and getting their input and addressing this long-standing issue. So I warrant to you, Prime Minister, and to the country, that we will continue to have the dialogue and the discussions with the consultants and other members of the medical committee as we undertake a reform, urgent reform that is needed to address the whole issue. Now, once we can we can reduce the backlog of cases, then we can start moving to a timetable. And that's why the implementation of a medical records facility, electronic facility, is so critical in this stage, because the hospital should no longer be requiring or asking of persons, consultant or other persons, to check a diary or to check a log. We should immediately have a system in place that can tell us how long a patient has been waiting for a surgical procedure, how long they've been rejected or turned back, and why. And with that information, I think that would allow us to make more informed decisions. And if we have to make process improvements, we'll make additional process improvements. But I would say to you that that is the approach that the Ministry of Health intends to undertake. Thank you.
I want to thank you, Minister, for your candid response. I'm sure that you are also experiencing the same concerns and questions that we have as a representative. I hear you on what is planned. I want to know that the day can come where an individual in this country doesn't have to know an MP, doesn't have to know me in order to ask me to make an intervention to get an early date for a surgery, and a surgery that they perhaps have been waiting on for 4 years. I wish that we can get to that point, and I wish that we can rationalize the consultancy services that are currently available to the hospital, while at the same time being able to look at the overall delivery of patient care. But you touched on an issue of patient delivery and the execution of services to the public. And I recall, I think it was last year, raising this issue, having been a patient not so long ago. I was given certain assurances when I raised it that the Queen Elizabeth Hospital was going to be moving in a direction to focus on patient care and certainly the delivery of the services. I'm just curious as to what progress has been made to ensure that there is contact being made with the patients via the telephone, since in a lot of cases we cannot obviously have people physically in the plant in the way that we may have done before. What are the steps that have been being taken in terms of telehealth to improve the service delivery to patients across the country?
Thank you very much. In respect of, and I'll ask the Executive Chair of the Queen Elizabeth Hospital and also the Head of Medical Services at the Queen Elizabeth Hospital to respond. But in respect to the process of, and I think you're getting to customer care and service deliverables, the issue of, I went to Harson's Point and I saw what they have there set up, known as a client relations department. and it is one that engages the families, that kept them up to date in respect of what was happening to their relative or friend at the facility. We also had an opportunity for them to present to us how they executed. And I thought it was worth it to see the clarification, the explanation, how it works. And that, along with other clinical services that they offer in terms of getting back to clients. That is one approach that I think we could use. And there's also another approach, and this approach is used in, for example, United States, where you have a person who's responsible for first impressions at a hospital. In fact, if you had to go to a Baptist hospital, they have a director responsible for first impressions. I'm not suggesting that we have to use that concept or job title, but what I'm thinking about is that in terms of changing the culture and also changing the operating processes at the Queen Elizabeth Hospital, we're going to have to look and see how best we can fuse that and to deliver a customer service that not only keeps patients informed, but also has the extended capacity to notify family and friends. For example, what we've been through with COVID, we've had a situation where the hospital had to limit visits to the facility in order to protect its patient population. Now, a similar approach being utilized across all hospitals in Barbados, not only the Queen Elizabeth Hospital, for example, the geriatric and the psychiatric hospital, where we can have that outreach and that persons remain in communication with hospital officials. Like I said, it will take, I have a concept of it, and I think on where it should go. I have a concept but we first have to involve the stakeholders in the discussion process. But I do agree that the whole issue of customer service has to be fine-tuned. And once we fine-tune that so that we achieve the appropriate deliverables, I will bring, obviously, to the leadership of the ministry a little different perspective in terms, not because I spent most of my life working in the private sector, but I also believe that there's some things that we're going to have to measure and we're going to have to change, and that there's some things we're going to have to do in the shortest possible time. But I think overall, the goal is to improve customer service at the Queen Elizabeth Hospital by whatever department we call it, by whatever measurement. And it's not like a significant exercise. It's knowing what is required, what has to be done, and what we want to accomplish at the end of the day. I'll invite the executive chair of the Queen Elizabeth Hospital to respond as well.
Yes, thank you very much, Deputy Prime Minister and Minister, for those opening remarks. We have undertaken about 4 or 5 different initiatives, certainly to improve customer service, or we prefer to use the term to improve the patient experience. That is the term that's used within hospital parlance. During COVID, we would have established a help desk. There is a help desk. We're the only help desk in the country manned by physicians, EMTs, and nurses. And that help desk essentially was established first as an interface between families who are unable to obviously get access to their relatives because of the restrictions on visiting within COVID. And what we found, the response to that help desk has been so overwhelming that we've expanded it. It now runs from 8 a.m. in the morning until 10 p.m. at night. And that desk essentially is a critical interface between patients who are falling between the cracks, who are not getting their appointments on time. And because they're physicians or clinical staff, they're also able to intervene and advise. So we find having a clinically based help desk as a patient liaison service to be important. I think we have to get the word out more about that service so that people can be aware of it. Our ophthalmology department has also been one of the most innovative in the hospital in terms of telehealth and the consistent use of telemedicine. And they have actually piloted telehealth services for the patients that are in their facility. Because they're dealing with eye care, perhaps they're able to do this. So we are actually utilizing telehealth and piloting a small electronic medical record system within the ophthalmology department, which is one of our most in-demand departments, so that we're able to, as we roll out, as Mr. Burgess would have said, we've addressed what are some of the cultural, process, security, and other issues that have to be addressed to roll out an electronic medical record system on a wider scale at the hospital. We also, within the accident and emergency room, recognized that we had some positions called patient advocates who had been functioning for a number of years, perhaps 7 or 8 years, Louise, or so. But we found that the public has been complaining significantly that that service has been less than stellar and less than responsive to their needs. So we've started the process of transitioning that service to a more modern customer service, logistics-based service, and that initiative is actually started and is underway. We also, in terms of improving the patient experience at the hospital, have started a process of rounding. What we do is multidisciplinary rounding between nursing, human resources, and other departments. We round within the hospital and meet patients where they are and find out what are some of the issues that patients are encountering, and then we're in a position in terms of case management to deal with them very specifically. Our bed management unit also has a component that involves case management. So when we encounter patients who are on the wards and say they've been awaiting, 3-4 days for a CT scan or some initiative that will result in delays in them being discharged or coming to a final diagnosis, that rounding experience is able to pick those cases up and address them. And finally, we recognize that we need to use technology more effectively. We've been exploring an application that we can use within the hospital where in real time we can have patients actually touch base with us and say very specifically, my bed is not working. I've been calling for water and the nurse hasn't responded. I'm here for 3 days and I'm still not clear on my diagnosis. So we are actually putting an application in place so that we can have persons respond, specifically the help desk, and another department respond to be in a position to respond in real time to the issues that patients are facing. So in a nutshell, Minister Bradshaw, we recognize that the patient experience is an area that we've been weak on as an institution, and what I'm highlighting for you are some of the areas that we've been making very specific interventions. What we do have to do is establish, in my view, a department that is fully accountable for this. It's referred to as a patient experience department in many hospitals, and we're looking to build that into the firm establishment of a quality unit so we're able to report using matrices that we establish on the patient experience at the institution. I don't know if I've missed anything, Dr. Cave, Minister, through you.
Yeah, I will ask Dr. Cave to assist as well. Dr. Cave?
Yes. Clyde Cave, Acting Director of Medical Services. Thank you for raising the whole culture of communication, which is not just confined to the Queen Elizabeth Hospital, dare I say the whole country. But as a hospital, we are interested in the communication between our healthcare providers throughout the team and our patients. And I think changes are required on both sides as we move to improve this. You asked specifically about things that are happening. From the medical side, One of the difficulties imposed by COVID was that a lot of our senior medical house staff were transferred to help man the isolation centers, leaving very junior doctors under the supervision of a consultant. And that made the decision making perhaps not always as clear and the response not as quick as it should have been. So what we did to augment that, we tried for volunteers, and that effort was stymied both by the ability of our technology, our IT within the hospital, as you've heard about, and COVID restriction, on people entering. But what we tried to do was to utilize a help desk that have now done 2 additional services. The first one, which was started a month or so ago, is for all new admissions to the hospital for their next of kin to be called the next day, to find out if the family is aware of the location of the patient. As you know, the visiting and accident and emergency and admission to hospital is much less than it used to be. To see the families aware and if they have any questions. And also, as a separate exercise, the help desk is doing a post-discharge satisfaction survey. This is in addition to our QEH Connect websites and the traditional complaints mechanism through our clinical risk department, which can be accessed in person, by telephone, or by email. But what we're really trying to do is to move from a complaints culture to a culture of promoting satisfaction. That requires the input from both our patients and our staff. We are very often told when we fall short. Very rarely do we get the feedback as to the things we're doing well. So these are what we have done so far. With the post-COVID environment, when we can return to a new normal, it is certainly our hope that the communication aspect will be one of the top priorities to address. Thank you.
Thank you, Minister, and thank you to the team for clarifying a number of the things that are in the pipeline. I will say, though, that I do believe that some of these things may need to be accelerated. A lot of the things still seem to be works in progress. And again, based on the feedback that I certainly receive from patients, people who are pretty much experiencing life-threatening illnesses, there is always a sense that that level of interaction, that perhaps at that point or juncture when people really need to hear a concerned voice at the other end of the line, or even when they visit the hospital, having persons to just reassure them, just talk them through the process, that still is very much missing. But I would again be hopeful that a lot of what is in the pipeline and certainly being contemplated, that there could be the relevant follow-through. I would also just like to suggest that perhaps some partnerships with other hospitals who have tremendous experience in this area, in particular the area of delivering on patient care and support, perhaps be explored in greater detail. It is important that we learn from the experiences of others. A lot of this, really, we don't need to reinvent the wheel. But I can say from a personal standpoint that a large part of my recovery wasn't simply my medical team. It was also the persons that I met as I walked into the hospital. It was the security and how they treated to me. It was the maids in the corridor. It was the nurses. It was the people at the front desk. And at every juncture, it made a difference in how you were treated in the place that people are going to get care. So I just want to emphasize that, if it has started.